And they both serve as mental health interventionists in school sites in the Valley. So they have a really great perspective to offer on universal screening, which they'll be sharing today. And I just want to, we've changed up the format just a little bit of how people can sign up for our mini trainings event series. But I just want to make sure that everybody knows that we do have a brand new student behavioral health and wellness website. So that's a really great resource for all educators in Southern Oregon because we will be uploading a recording of this video to our website, which you can find on our resources library. So I will be sure to send that out in a post email tomorrow that will have some great resources for you all to take a look at, including a recorded copy of this video. All right. So if we can just do a little introduction and find out who's in the room today, if you don't mind putting in the chat box, we can see your names. That's great. If you don't mind sharing your pronouns, your position, and your school or organization, so we can get an idea of who's here. And if you'd like to, you can consider including an answer to one of these three questions. So just one thing that you're looking forward to. If you've ever done like a rosebud thorn share, this is kind of the bud. So just one bright spot in your future. Um, where you are at in a universal screening process at your site, perhaps just information gathering, maybe in the first year of implementation or 2+ years of implementation, or you can consider what you hope to get out of this session. Great. Well, I'm glad you could make it. Wonderful. Well, it's just great having you both here today. And we will have some time at the end to ask any site-specific questions. Okay. Um, so we do have some objectives today. And just to kind of point out that today's discussion isn't necessarily a guide for implementation because as we go through today's session, you'll see that it is an extremely strategic procedure. So today is more of a background building session where you'll discover the importance and value of universal screening implementation by discussing the current mental health crisis in our young people and also why school-based mental health support is important. We'll dig into the key features of universal screeners, and we will also establish important best practices for implementation to ensure that we're really increasing positive outcome for our students in addition to avoiding causing harm. And we'll just remember that as of right now, there is no standardized structure for implementation from ODE. So we're really here today together to gather information and a lot of key information, some key info from our mental health practitioners of our guests. And we'll be looking at some data, as I said, really breaking down the universal screener. So defining what those are, looking at key features of different screeners, some best practices, and then you'll be introduced to a lot of different screening tools. So you can really start to get some information about which screeners might best suit your needs. And we will have some time for some collaboration and discussion towards the end, and then we will ask you all to take a survey. I will point out, like I mentioned, we are recording this. I will be pinning the speakers, and I will also stop the recording before we do our discussion at the end, just for your privacy. All right, great. And I'll turn it over to Jody.
All right. So the first 3 or 4 little slides we're going to be sharing here and things we're going to be discussing is just going over some stats to kind of paint a picture for what we're screening for. Obviously, we are mental health providers, and so we're talking about it from that lens. But there's lots of things, as you'll see, that universal screeners can be used for. It can be around school culture. It could be around readiness for college, or whether or not kids feel certain ways about their peer relationships, things like that. And schools are going to use it very broadly, but we're going to talk about it from a mental health lens because that's where we see we're going to be able to have our impact. So the first guy up here, you can read along with these, but 1 in 5 caregivers, almost 20%, or right at about 20%, reported that their child needed assistance as a result of mental health crisis. That was in 2021, which obviously we all know happened in 2020. So these were all taken right after COVID, right? We started coming back to school and things started returning to some form of normal. And these trends are not anything really exhaustive that's been newer since then that I've been able to find. So these kind of still hold sway for kind of where we're at. 20.1% adolescents and 8% of adults report having a major depressive episode in the past year. So from 2020 to 2021. 4.8% adults, 12% adolescents reported serious thoughts of suicide. And that painted that picture of the suicide risk in Oregon versus nationally is 19.5 out of per 100,000 versus 14.1, which shows that we've been higher than the national average for I don't know exactly how many years, but a good while. Oregon's always been that higher. So it might mean that just points towards screening for those kinds of things and maybe having an opportunity to catch those before it progresses is an important part of the universal screening process. So yeah, pass it to Lisa for this next one.
Oh, you're muted, Lisa.
Sorry, I'm new here. Just kidding. So we wanted to take a look at what mental health looks like in our area from the Youth Mental Health Survey. And that's given to, as you might know, 6th, 8th, and 11th graders. And we used 8th grade for our examples. And I apologize I did not put Klamath County in this, but I have Jackson and Josephine County. And as we can see, Jackson County is a bit higher than the state average for poor emotional and mental health, 18.3 to 12.9%. So yeah, Jackson's 18.3, Josephine 13%, and the statewide average is around 13%. And you can go to the next slide. And this next slide, it asks the question, have you ever felt so sad or hopeless almost every day for 2 weeks or more that you stopped doing your usual activities? And it kind of shows around 30% of 8th graders felt this way. And it's important to also look at the categories for prefer not to answer and unsure, because that could raise the percentage, right? So that could mean almost like 50% if you're adding all of that up. So just a good glimpse at what we're seeing in that category. Can you change slides? And then this slide is, have you ever considered attempting suicide? And let's see, we have, and I apologize, I'm reading off some of these because of the stats here, and I have my vision. So the state average is around 11.6, and we were slightly above that, around 13%. And again, we also want to look at the unsure and prefer not to answer. That could jump that up to 30%. And about 5.8% of 8th graders from Jackson and Josephine County said that they attempted at least 1 or more times. I also added some stats just for 11th grade in case there were some high schoolers here. So we see that around 17% in Jackson County said yes, they considered attempting suicide. And in Josephine County, 12.5 said yes to considering attempting suicide. Another thing that we had just researched in our conversations recently, that in Jackson County, we lost 4 young people to suicide in 2023, and that young person is defined from 5 years to 24 years. And in Josephine County, there was 6 young people who died from suicide last year. Next slide.
All right. So it's missing a little section over there talking about the Surgeon General's 2021 Declaring Youth Mental Health Crisis. And we can see, I'm sure you guys are educators and work in the school field, and you can, if you've worked in that environment from 2019, 2018 onward, and then now to the last 4 years, there's a recognizable difference in how each of these domains have been affected. Especially with society was shut down and held for a while. Environmental, people were spending a lot more time at home, not in social environments. The communities were changed to their family. I had a hard time being able to keep some level of confidentiality, even providing services to people in the home. So there's a lot of ways in which those things will persist beyond just that very weird couple of years when we were dealing with those things. It's always wanted to point out, like, all these stats even are after 2020. And if we were to go back, 8 years or something, it would paint a slightly different picture. But the one that would not is that tends to hold sway is suicide ideation has always been higher in Oregon than it has been nationally. So that's why we're there are some federal guidelines and things pushing to have universal screeners start, but there is nothing from ODE. But that is kind of in the process. Why this meeting is for that. Put that out there, get people who are working in the schools to start thinking about implementation of these things on a more regular basis. All right. So next one, just gonna, looks like it's a copy slide. Yeah, there we go. So this top one, I think, is an important one to look at. The most common statistic on gaps between onset of issues to treatment is about 11 years. Which you can think about that. I know the students are struggling in first grade. They may not be accessing services on average until like really in depth or being referred to community-based resources, especially because this next part is talking about that youth are most likely to access services from schools and any other setting. There's a lot of obvious reasons for that, especially for younger students. They don't need to be transported anywhere. They're just called out of class. I work in all grade levels, but right now I'm mostly working junior and senior high school, and their ability to have their own agency and feel like their treatment is self-created is also another big thing. I've noticed that from working in many different settings. So if we're going to be doing screening and we're going to be doing a referral process, one gigantic benefit of having on-campus resources is that the follow-up rate is going to be much higher, and the engagement rate from the student is also going to be higher. So we find, and then let's see. So yeah, closing that gap of underserved and marginalized populations. People often assume that is simply people who might have low socioeconomic status, or especially migrant families and their children, which is definitely true. But a large gap of people who are very underserved is ironically people with private insurance. It is very hard to seek services if you have private insurance if they have private insurance through their parents, because they're not going to be able to access a lot of their primary providers like Options and Kairos and the county, Family Solutions. There's a lot of agencies. They do not bill private insurance. The only people that do are people in private practice. And if they're full up, especially for adolescents and children, there's it is not uncommon to have a 4, 5, 6 month wait list if you have private insurance. And many educators, that's what you have. You have insurance through your work and you cover your dependents. So that's actually usually a very underserved population. Right. So now we're going to start getting in after laying that foundation and groundwork. We're going to start talking about screeners. I wanted to differentiate between these 3 different, we're talking about universal screeners specifically, but it's kind of like a tiered system. You can see it as a universal screener is something you might do maybe during enrollment. You're going to have everybody fill out this, questionnaire that will give you maybe an example or 2 later, and will probably be in the post email. You can send examples of what these things might look like. And that's going to be to every single student, no matter what, they're going to fill something out. And then a focused one might be a specific classroom who, there are a lot of high-risk students, or if there has been a large event like a death of a teacher, or there's been anything that might indicate that the specific group or class might be vulnerable, need to be, you can do a kind of more focused, that's still going to be generalized, but still just kind of catch the kiddos who might be struggling. And then an indicated screener is going to be something that more like myself and admin would complete if a student was displaying really problem behaviors, or if they're making suicidal statements or joking about things a lot. That's going to be more like a targeted, we're going to pull this kid aside and do an indicated screener. Most, from what I saw from you guys' jobs, you wouldn't be doing those, but universal screeners, you might be one who, or focus screening might be administering, giving them to the class and collecting them. But really this is about those three different levels: whole school, targeted group, and then individuals who might need to be screened for something more specific. Right.
So some key features. Oh, sorry. Go ahead.
Yeah, this one's still me, I think. Yeah, am I? Well, no, you're right. You go for it.
That's okay. So some key features of a universal screener. Systematic screening is a proactive approach for students who may need support beyond the tier 1 efforts and at the earliest signs of concerns. So universal, like Jody mentioned, all students attending school are screened. And another feature is it's repeated, right? So best practice is to do it between 2 and 3 times a year. If you do it in the spring, just leave time that you could complete the interventions and refer and follow up. It's proactive, right? So you're not only identifying students needed to be connected to those tier 2 or tier 3 services, meaning like small groups or direct intervention, one-on-one intervention. But you're also looking at the overall health of your community. So if you're screening and it's showing, let's say, higher rates of substance use in your school, you then want to probably put more intention and prevention supports in your tier 1 around prevention around substance use. So it is important to be proactive, and then psychometrically sound. You want it to be reliable and valid for the intended population. So you want to make sure your screening tool corresponds to relevant ages, grades, languages, how you're delivering the screener, and all of that. Next slide. I think this is you, Jody.
Yep. So universal screening, the thing I highlighted down at the bottom, made bold, is the whole point of trying to do this is just prevention and early intervention. I talked about the 11-year gap, which whenever I share that statistic, people are always kind of surprised, because it's not going to say that every student who struggles is going to have 11 years of treatment. But when we're talking about just onset of somebody struggling with mental health disorder to them getting engaged in ongoing treatment, is that 11 years, which is even shocking to me. That's because I work in a situation where I get to have immediate, meeting with students. It's very easy for someone to get mental health services, but that's not the case in most schools or school districts. Most people don't have on-hand mental health providers, which obviously I hope changes. But universal screening is going to help us find that prevention and early intervention. We talk about prevention versus postvention all the time. There's like 2 buzzwords all the time in the mental health field, also as educators. So if we can prevent these things and we can close that gap, we're going to see, we can see a drop in, substance use persisting for years after high school, when we get to see culturally and anonymously what these kids say about what their substance use. There's also universal screeners that we're going to use oftentimes to identify, and kids are going to be putting their name on it. But there's also like the Youth Truth Survey is something that is not, I don't think that one is, but there are often anonymous ones where they're just going to get a picture and kids might be a little more honest, so we can see, okay, just like Lisa said in the last slide, how much are we really having drug use and abuse, and maybe substance use versus substance abuse issues, and do we need to have more intervention around that? That's finding that prevention, or getting that early intervention, so we can prevent the ongoing issues. Those are suicidal ideation, obviously, but drug use is a big one. We've seen an uptick ever since COVID with substance use of specific things in our communities. So that's the first thing I would leave with, is early intervention is our primary reason of why we're even going to do this.
So we're going to discuss a few best practices in screening. There is a link that shall be sent in email, and there's a lot more listed. So I just captured a few to talk about. Youth and family voice. It's really important from the beginning stages to the very end that you're always incorporating youth and family voice and getting input from them and making sure that they're aware of what the process looks like, all of that. You want to make sure that, like I mentioned before, that this is informing your MTSS and your supports that you have in your school. You want to, it's used for early identification of students. And I'll talk more about this in a later slide, but mental health staff needs to inform the process. I mean, from beginning to end, from assessment, intervention, referral, all of it. And then also just ongoing consultation to ensure that you're in compliance, right? So those are a few that I captured. There's a lot in that list that I recommend you look into. And there's the potential for some harm and negative impacts doing universal screenings. You don't want to screen for specific diagnosis, single item or suicide, single item, especially suicide or self-harm, like on Jody's previous slide where it talks about identifying needs, strengths, all of those other things, positive relationships. So not just one item. A big negative impact is insufficient follow-up. I've heard from some folks that they didn't have enough time to follow up, and that's really harmful to be screening for this and then not follow up on that. Using for high stakes decision making. So if you have, for example, questions related to substance use, and then somehow that's being used maybe for a referral to the dean or something. So we want to really make sure that it's not being utilized in that way. And then not having adequate informed consent. That there's a lot of legal, ethical issues that come with that one. So we could talk more about that in another slide. Next slide. So there's a link here, and it's also in your email. This checklist comes from the Mental Health Collaborative, and it goes through, and it's a really nice tool to be able to use to kind of assess all the stages before you begin considering doing universal screener. So the first stage, your exploration stage, you're determining your levels, like kind of where you're at, right? So what are your current practices? What's your need in universal screening, including your goals, objectives, what questions are you looking to answer? Which screener might you use? Determine your student population. If you're not going to do all the students, why? Why only a subset? Like these are the questions you want to ask yourself. You want to determine the buy-in from your parents, from the teachers, from your admin, all of that. For readiness, you want to determine how ready is your school to do a screener. So is there an expert on your team? Are there resources available for intervention? I consider doing like a real resource mapping of who's in your school and then who's locally in your communities and what resources are available to meet the needs of your students. The adoption phase, so that's kind of selecting the screening instrument. Is it an appropriate screener? How much is it going to cost? The technology piece to it. How frequent are you going to screen? Is it just going to be a classroom in the beginning to try it out, that type of stuff? Opt in or opt out. There's a whole process there with informing parents and doing the whole opt in and opt out for that. Trainings, identifying the trainings you might need. We'll list a few at the end that we recommend having your mental health staff, but even your whole school staff, that would be beneficial. And implementation, you want to determine your levels, school's level of implementation, and how do you use the results, and how do you make sure that your referrals are effective, and then how do you communicate concerns with your families if those come up? How do you minimize the time between screening and referring to services? So those type of things. And then when it comes to data collection and storage, you want to determine how ready you are to do that. In schools, we have FERPA, there's also HIPAA we have to be mindful of, who has access to the data. And I know Jody mentioned, having the names. I think we want to make sure with that data and not having a identifier would be best practice, maybe a proxy ID with a student ID. So that's not like right there if someone was able to see the results. Next slide.
Okay, so this is the kind of acronym soup of a bunch of different things that you don't need to worry about. We want to just throw up these, the main thing, you look at those headlines of these are more, targeted or focused screeners. And in that middle there, I put in bold and underlined the Check Yourself survey is something that is created by people who also created this screener called Espert, which is down there in the substance use category. But it's not just for substance use. It's a broad kind of a universal screener you can use to ask lots of different questions. I don't know if it's already in the email. I'll check with Shelby, but there's a link that I have that kind of, you can actually look at it and see all of the examples of what the questions will be. There's going to be some that might have a scale. They're going to ask about ask about home life. They're going to ask about how easy it is to ask for help from your teacher in your school. How easy it is it if you were struggling with a peer to access the disciplinarian or the assistant principal, all those things. And then each of these other screeners can be more targeted. If you know and see the student is struggling, a school counselor might then have a follow-up meeting. The obvious when we talk about follow-up, it is not walking away with anything other than a consideration before putting universal screeners in place, especially if they're going to measure suicidality. Is follow-up is everything. I've been in situations in previous placements where they did this. They had, check marks on kids who were imminently at risk for themselves, not just having ideation, but saying that they had past attempts, which automatically puts them in the red for needing screening, or that they have intention and had a plan and identified means. And then you have not everybody to see, maybe those, if you have a bigger school of 2,000 kids in those screeners, if you get 45 to 60 of those that pop up, you got to check in with all 60 of those before they go home, or you at least have to inform parents of the danger, but really you're now responsible to make sure they're safe. So before you implement something like that, you got to know, hey, we're going to have a day in which maybe all school counselors need to be available, or we need to have community resources come in to be able to do that follow-up and make sure the safety is there. So we want to reiterate that fact, because then we would be moving, if we have that from the Check Yourself survey or something similar to that, then we would have more targeted things that we would want to follow up on and do on that more focused screening or indicated screening. Yeah, right. Next slide. And follow-up doesn't always mean access to mental health services. There's a lot of different things from referral and follow-up that it can be. I mean, I think that in general, depending on the makeup of your school, if you have the school counselors, they're going to maybe be the people who do that initial kind of triage and see where the kid's at. But it might be, check-ins with a mentor. Like, I guess you think of kids who are on the football team, or they're engaged in a certain community and they identify someone as a real strong mentor, their coach, or they're in the drama club, and the person who runs that is like a school personnel they really trust. It can be simply encouraging that connection and seeing where they're at. But that's for things that are minor. They're feeling like the school is feeling unapproachable and they don't think that they can get help when they need it. Those kind of things they're going to ask around culture that can be remeliorated, rather than the kid just holding that long, because there's a self-fulfilling prophecy that's going to happen. Kids are going to see it that way, and therefore the school is going to seem like a hostile environment. They're not going to keep seeking help. So it's kind of like us, when we gauge it and we can address it and show the kid that they don't feel invisible. Some kids fly under the radar, especially in a larger school, where they can just silently be unhappy with the experience and feel like people aren't going to watch out or see where they're at. And that's going to be justified by them then wanting to be invisible. So follow-up isn't, and referral isn't always, hey, just the mental health aspect. That's a big portion because we want to really affect those stats that we talked about earlier. But it does also catch the kids who are in between. They're not struggling with a mental health crisis, but they are just feeling invisible. That's the best way I think I could put it. So there's lots of different responses and referrals to community organizations for mental health, or just school personnel, counselor, a nurse. It could be the administrator they trust, it could be a teacher they really care about. And then there's small group interventions. You might find that a lot of these kids clump into something that might be just There's questions in surveys about eating disordered behaviors, which is one of the best treatments for eating disorders is having group treatment. There might be a lot of self-harm, non-suicidal, self-injurious behaviors, right? They don't have suicidal thoughts, but they have self-injury. Another thing in which groups can be very effective in treating. So sexual abuse victims, again, another thing, if kids are all there and there's resources for it, we can have group interventions for students that is better than just individual at times to build a community. So there's a lot of different responses we can do and referral sources to do that with that comes from these screening tools.
So school-based mental health, the role is so important in this process. That's counselors, social workers, school psychs, nurses. They should all be on the team, and they're, like I said, the heart of the process, right? So we're the ones that are responding, following up with the students who've screened for a concern. We identify and partner with health agencies, mental health, substance use, any kind of social support agencies. We should have current prevention training. Absolutely. If you're going to do this, be current on your either assist or USAVE or assessing managing suicide risk. You are also responsible for the referrals and the process to follow up, make sure they're connected, the procedures to connect families with other partners, all of that. So we play probably the most important role in this. And then next slide. But the admin, our principals, our leaders, they are also really important in this process, because if they're not 100% on board, it's not going to work as effectively, right? Then you're really working hard to try to get buy-in from other staff. And if you don't have that leadership, it just won't work. So leaders' roles, they create effective teams, they assist in the planning. They should really be implementing effective tier 1 and tier 2 practices. They should be looking at the data, offering the professional develop opportunities, ones that we used when I was doing this work, motivational interviewing, the ACEs training, the trauma-informed practices, PBIS, those type of trainings were very helpful. The other piece for admin is they help with the technical and legal assistance. So helping with identifying the screening tools, problem solving, the opt-out letters or opt-in, whichever one your school decides to do. And then also just that trauma-informed practice. So they need to make sure that the screener aligns with the needs of their community, that have an understanding around the differences of universal screening rather than screening for just trauma or suicide. And then also just be really youth and family driven. So that could look like holding family nights, just educational opportunities for them to learn about the process and what that might look like for their student. And I think that's the last slide. So we have some time for questions.
Yeah. Thank you guys so much for all of the information. So we are open for any questions that you all might have that are specific to your site or anything that's coming up for you, any clarifications that you want to make about the points that these two shared with us. I put some potential questions on there just to kind of get the juices flowing. When would you use a screener? Any questions that you have about best practices? Really thinking about like your setting and your population. When Jody talked about all the different types of screeners that are available, what types of screeners do you think might be most relevant and applicable for your school and your students' population? We can also dig into comparing any resources that are already available. And then really like thinking about what kind of supports might you need to do this well. So we could even use this as like a troubleshooting conversation. When you start thinking about this in your own school, what are some supports that you might need? So I'm glad that Lisa brought in that component about the administrators. And then Lisa, before I stop sharing so that we can dig into our discussion questions, I'm wondering, do you know of any relevant trainings that might be happening in our area or available online off the top of your head?
I know there's an assist training coming up. Um,
Okay.
I honestly, one of the most important ones. So I used the Expert Check Yourself screener for 4 years in the Seattle area, just south of Seattle. And I have to say, I'm a huge proponent for universal screening. There's so many things that we captured, and sometimes it's just such a brief intervention that can make such an impact. And we just, we don't know that our students are going through it if we're not seeing these like big behaviors or we're not hearing from it from their families, right? So I've really appreciated being a part of our expert team. And with that, I would say the motivational interviewing, we all had that. And I mean, even in my, as a school social worker, I had that in my, prior, education, but it's always good to be refreshed because that's what you're really doing after you're looking at the results. You're really trying to just get them to open up and kind of gauge really like where they're at and some of the questions that they answered and how they answered them. So
I'd just
other
be
spe
curious from each of these from Cater High School and you got in Gilcrest, it sounds like elementary. Is there anything from either of your guys' schools that are already implemented that you know of? Any kind of screening tool at the beginning that might be during enrollment that checks in with kiddos to see